Hello, everyone. Welcome to the National Indian Council on Aging's Tribal LTSS Home Healthcare Webinar. My name is Becky Al Morgan, and I work as a project coordinator here at NICOA. Thank you for joining us today. Our presenter has a fascinating talk planned, and we want to hear from you as well. So one thing to do to start is to please share in the chat box your name and where you're calling from. So for example, I'm Becky from Albuquerque. It's neat always to see all the wonderful places people are living and working. Our organization, the National Indian Council on Aging, or NICOA, is a nonprofit established over 40 years ago, which has been and remains dedicated to improving health, social services, and economic well-being for American Indian and Alaska Native elders. Thank you to our very knowledgeable presenter, Cheryl Ingram. We're so excited to hear her share her experiences and learn more about home health care. Thank you to the great team at NICOA who helped us create this event, Larry Curley, Cindy Curley, Kayla Sawyer, and Desiree Lapahi. So let's cover a few housekeeping details now. We're recording this session and we'll post the recording on our NICOA website as well as our LTSS Compass website in a few days. You can find it at the top of the homepage by clicking the newsroom and then videos. We encourage your questions. You can type them into the chat box or click the raise hand feature and we can unmute you so you can ask your questions or make a comment. My colleague Kayla Sawyer, our technical communication specialist, can demonstrate and explain further. And Kayla?
You'll find the raise hand button in the lower black bar of your screen. Just move your mouse over the Zoom screen and you'll find it. It looks like a raised hand and says the word raise hand. I'll demonstrate right now. You'll see that a small hand has appeared in the upper left-hand corner of the box that bears my name. To lower the hand, just press the same button you did to raise it, like so.
And then you'll be able to unmute the person and then they can ask their question instead of having to type it in. If we run into technical difficulties, the other way is simply to just type it into the chat box as well. Thank you very much, Kayla. So the other approach, sometimes if you're running into technical difficulties, as we did this morning, is to leave the meeting and rejoin. And sometimes that fresh start can be very helpful. We'll be pausing throughout the talk for discussion. So please join in. We really hope to hear from you and we can make this as fun and interactive as possible. As part of the work of NICOA and with support from the Administration for Community Living, we created the Tribal Long-Term Services and Supports National Resource Center. The name we gave the project is LTSS Compass because our goal from the beginning has been to help to make finding your way through confusing processes and regulations easier for elders, tribal leaders, and Native communities in general. Please take a look at our website at nicoaltsscompass.org. And I see a raised hand. Do we want to see if we can, looks like Lorena. Let's see. Figure out, bear with me. Lorena, if you're able to enter your question into the chat, I will try and make sure we cover it. Thank you very much. Let's see. So we are presenting 3 webinars on home health care, assisted living, and program management. Desiree Lapahi, our data analyst, will explain the process for choosing these 3 topics. Desiree, can you unmute yourself?
Hi, everyone. So excited to be here with you all. So as stated, my name is Desiree Lapahi. I'm the data analyst at the National Indian Council on Aging. We came to this conclusion when we conducted a survey back in the fall of 2020. It was a long-term service and support survey to tribal leaders. From the survey, we received 85 responses across the US. Within those 85 responses, we identified the 3 major categories as infrastructure, support services, and management. Now, from those 3 major categories, we decided to create webinar trainings on the top topic in each category. From the supportive service category, the top choice was home health care. Thus, we created a webinar training on home health, which we hope you will enjoy and learn from today. From the infrastructure category, the top choice was assisted living facilities. And from the management category, the top choice was program development. So this survey conducted the needs of tribal leaders, hence the training that you will be learning about today. Back to you, Becky.
Okay, thanks a lot, Desiree. Now I want to share the biographies of the subject matter experts that you'll be hearing from today. Cheryl Ingram is a registered nurse with 38 years of professional experience, 35 of those years of which have been solely focused on the home health industry. She has successfully accomplished the startup of 2 new home health agencies from inception to full operational status. During the initial phases of the startup, she donned many hats and roles, which allowed her to learn and master her skills in all aspects of running a home health business. In addition, she has experience as a clinical supervisor and as an administrator of home health. Prior to home health, she worked in the hospital setting in ICU and a post-open heart unit. Ms. Ingram graduated from the University of Tampa with a Bachelor of Science in Nursing. She is currently working as a contractor providing subject matter expertise to those organizations wanting to utilize her knowledge and professional expertise to educate others on current home health requirements. 2 other experts will be joining the presentation today. Ms. Cindy Curley is a consultant currently assisting the National Indian Council on Aging on their long-term services and supports project by providing current research on the Medicaid and Medicare reimbursement processes and procedures. She initially aspired to pursue a law degree by first seeking certification as a paralegal. She revised her goal and began her career as an owner-operator of a successful medical claims billing and consulting business with over 12 hospitals and clinics as clients in Nevada. One of those clients led her to working with tribes in Nevada as a financial and administrative officer and health director for more than 12 years. Upon leaving Nevada, she was contracted with eVentures Group, a behavioral health organization based in Salt Lake City, to perform marketing and collections, contracting, credentialing, and billing issues for EDG on and around the Navajo Nation. Later, she worked for Rehoboth McKinley Christian Hospital in Gallup, New Mexico, as their interim administrative director to start up their BHS residential treatment center and begin to lay the groundwork for accreditation. Her goal has been and still is to advocate for and help improve the lives of Native Americans utilizing her skills and knowledge. Larry Curley serves as executive director of the National Indian Council on Aging and is a member of the Navajo Nation with over 40 years of experience working in the aging and healthcare fields. Collaborating with Congress, other branches of the federal government, and national organizations on aging, Larry developed support for programs affecting elder American Indians and Alaska Natives. Mr. Curley received a master's degree in public administration and a certificate in gerontology at the University of Arizona. In Pima County, Arizona, Larry's work as a gerontological planner was instrumental in establishing a county public fiduciary program. In Washington, D.C., he worked as a lobbyist to successfully advocate for the passage of Title VI of the Older Americans Act, an amendment he authored. Mr. Curley directed the Navajo Nation's Head Start program, one of the largest Head Start programs in the U.S. Additionally, he continued his legacy of elder advocacy as a nursing home administrator of a tribal long-term care facility, as a hospital administrator in Northern Nevada, and as a college instructor at the University of Nevada, Reno, and Eastern Washington University. Mr. Curley was named Assistant Dean of the Four Corners region for Burrell College of Osteopathic Medicine. He served as public representative on the American College of Physicians Clinical Guidelines Committee and as the Director of Program Development for the Rehoboth McKinley Christian Healthcare Services in Northwest New Mexico. As you see, we have an esteemed group, and now I want to thank you very much and turn everything back over to Ms. Ingram. Take it away, Cheryl.
All right. Well, thank you everyone for joining the call today. As Becky said, my name is Cheryl Ingram, and I'm here today to provide you with information on benefits of receiving home health. And I just wanted to tell you a little bit about me, why I got into home health. As Becky mentioned, I had been a cardiac nurse, worked in open heart and ICU. And while I was working in the hospital in ICU, we had patients that had to go home with permanent tracheostomies. And for those who don't know what that is a hole in your trachea. And that means that you have to plug up that hole or you have to use a device in order to communicate. Well, in the hospital, everything had to be done under sterile technique as far as cleaning and suctioning. But once the patients are at home, I was able to go in and teach them a clean technique and how to manage their tracheostomies at home. And, that introduced me to home health. I became part of the family. They would be waiting for me to get there. And that's how I got bitten by the home health bug. I've done every type of home health care that you can think of, from wound care, different types of IVs, medication management. I've taught patients about their diseases and diagnoses and have been in all types of situations, and I've absolutely loved every minute of it. So, but before we get started on the presentation, I want you to get your thinking caps on. So I'm going to tell you a riddle. And if anyone that knows the answer, please let us know, raise your hand or type it in the chat box. So the riddle is, there are two mothers and two daughters that went fishing. Every person caught a fish. How many fish did they catch? Does anybody know? And don't be shy. Anybody? Stephanie, she said two. And that is correct, Stephanie, two fish, because every mother is a daughter. So I just wanted to put that out there to get you thinking a little bit as we go along, and to get everybody to relax a little bit. I'm going to tell you a little joke. Hopefully that'll kind of ease the tension a little bit and get everybody comfortable and willing to ask whatever questions you have. So this is about bad eating habits, and I'm sure we all know someone, including maybe yourself. I know I've experienced bad eating habits, and there was a mother who complained to her doctor about her daughter's strange eating habits. She said to the doctor, all day long she lies in bed and she eats yeast and car wax. What will happen to her? She asked the doctor. Eventually, he said, she will rise and shine. I thought that was cute. So that's my joke. And as we go along, everybody, please feel free to ask whatever questions that you have. So what is home health? Becky, if we could go to that slide, please. Excuse me, objectives. Let's go to the objectives. Okay. For today's presentation, we'll be talking about what is home health, how and why home health was started, who pays for home health and what is covered under this benefit, and what is needed to set up home health and the differences between setting up an agency or utilizing an already existing agency. So next slide. So we're going to talk about what is home health. Well, it's a way to receive medical care without individuals having to leave their home. It's a way for individuals to become independent by receiving medical care in the home, where a nurse or a therapist will come in and provide instructions on self-care. And the length of care can be up to 3 weeks for short-term care, or it could be a few months for long-term care, depending on the diagnoses. For instance, maybe a nurse may be coming in to do teaching on a new medication. And we all know that well, most of us know that it takes 21 days to develop a habit. So, that's approximately 3 weeks. And so it may be 3 weeks that the nurse is coming in and teaching the patient about their medication, when to take it, the right dosage, and then making sure that that medication is working for whatever reason that it's been prescribed, and reporting back to the doctor. Or it could be a few months, depending on, maybe they have a wound. It's taken a while for that wound to heal, and so it may take a little bit longer to promote that wound healing and get it moving in the right direction. It's also a way to reduce hospital visits. It's a way to help with recovery after a hospital stay. In order to prevent rehospitalization, home health clinicians can provide health care services and coordinate those treatment plans with the doctor. They can call the doctor to give them a report, or they can provide a written summary, or they may even request a telehealth visit so that the doctor can see what's going on with their patient. And home health is provided by nurses and therapists, and it's not to be confused with home care, which we're going to talk a little bit about that as well. Okay, Becky, next slide, please. So home health requires the skills of a nurse or therapist to provide care that's ordered by a physician, and it's covered 100% by Medicare or Medicaid, as long as the criteria is met that's been set by CMS, which is the Centers for Medicare and Medicaid. There are also programs called home care, which is funded by Medicaid, depending on state guidelines, that will pay for home health aides to assist with bathing, personal care, meal prep, activities of daily living. And in some instances, depending on the state requirements, they could provide nursing as well. Okay, Becky, next slide. So Medicare is available to those 65 and older, or for those that are disabled or have end-stage renal disease, and it doesn't matter what level of income that you have. Medicaid, on the other hand, is available to low-income individuals at any age. However, you have to meet the state federal income guidelines. And each state, it's important to remember, has different programs for Medicaid recipients with different requirements. North Carolina is different from Arizona, which is different from Colorado. But the one thing that we should remember is that every state has income requirements. So that's the same between the different states. And Medicaid's funded by state and federal governments. However, it's the state programs, the state that oversees those programs. Okay, do we have any questions on what home health is? I know we've got to have someone that's wondering, maybe there's something that I did not mention, or you have a question.
Hey, Cheryl, I just thought I'd jump in and say that we have a bunch of people from all over. There's Josie from Flagstaff, Georgia from Parker, Colorado.
Oh, cool.
Louie in Chicago. Wow. And Sister Mary. Oh, hi. Hello from Idaho.
Cool.
That's awesome. And then Helen is from Tulsa calling in. Greetings from Hopi Land in Arizona. Beatrice. And I can't say the name of your village, Beatrice. Aravi, maybe. I'm Rundell from Reston, Virginia. Karen, and she's a Title VI director, Santa Ynez Band of Chumash Indians. Myra from Santa Fe, welcome. Brianna, Seneca Nation, New York, wow. Lorna from Alaska, wow. She's a community health representative manager. Kristen Moore is from California, Grand Terrace. Georgine Lewis, Pima County, Salt River, Pima, Maricopa County, Arizona. Rowena Vicente from Crown Point, New Mexico. Let's see.
Nice.
There's a question in the chat. What type of home health care can you receive at home?
Well, pretty much you can do anything in the home. The one thing that's typically not done are blood transfusions. So, but pretty much anything else, wounds, there are wound vacs that can be used in the home, IVs, IV antibiotics, just about anything can be done in the home, which to me is amazing because we've come a long way in the type of things that can be done in the home. And the acuity level, I have to say, has probably increased as well. So there are patients that go home that you would think would qualify to remain in the hospital, but they send them home on home health because they can recover quicker, and then clinicians can come in and teach patients how to manage themselves at home.
Okay. There's another question that says, can you get home health care through Medicaid or just Medicare?
You can get it through Medicaid, but again, you have to meet the Medicaid requirements. And but home health is available through Medicaid.
Okay. And then Shelley has joined us. Let's see. She's Tribal Health Center, Confederated Tribes of Umatilla, Pendleton, Oregon. So we've got people from New York to Alaska to California.
Awesome.
So it's a good crowd.
Nice.
Larry and Cindy, do you have any comments or questions?
What medical providers are required in order to bill for home health care services?
I guess one of the questions that I was just thinking about is, once you set up a home health agency, who are the people who are meet the requirements for sending in the billing process?
What providers?
What provider?
I'm not sure I understand what you're asking, Larry. You want to know what providers can bill?
No, in order for home health care to be a billable services, what are the minimum provider levels, like RN and up, RN, nurse practitioners, overseeing physician, for those examples?
Okay, so for Medicare billing, and we'll go into this a little bit more in depth, but you need to have registered nurses. There has to be a skill required, so there needs to be the skill of a nurse or a therapist. So you need to have RNs on staff. You need to have physical therapy, occupational therapy, speech therapy, social services, home health aides available. And all of those services are billable. Now, and then you have to have a physician that oversees the care for the patients. And then doctors can bill for home health oversight as well.
Thank you.
Did that answer your question?
Yes, thank you very much.
Hey, you're welcome.
Okay. And then Sister is asking, is Medicaid a state funded or federal funded program or a combination of both funds?
It's a combination of both. However, states oversee their own state Medicaid programs.
Right. Thank you, everyone, for your questions. And we have one more. Have you seen an increase in home health services due to COVID?
Yes, there definitely has been an increase due to COVID because patients that have been admitted to the hospital with COVID are the patients that are really sick, and it takes them a little bit longer to recover. And so they're sent home to continue with that recovery process. And home health will go in and teach them how to be safe in their home, how to prevent the spread of the virus. Maybe there's other people living in the home. And the clinicians will go in and help them with strengthening exercises, because most of the time, after they've been in the hospital, they become very weak. They're short of breath, and so clinicians will go in and help manage them at home, and then report back to the doctor. And with those patients, they also will set up telehealth visits so that the physician can actually see what's going on with the patient.
Very good. Thank you. Thank you, everyone, for your questions. Keep them coming. This is good.
Yeah,
All
very
right.
good.
I think we're to the end of the chat questions, Cheryl. You want to go
Okay,
ahead?
well, then let's talk about how did home health get started on the next slide. So Medicare was created in 1965, and it was the first system of public health insurance. It was also part of the law that was implemented. Home health was part of the law that was implemented with Medicare to help cover the healthcare needs of older adults. However, home health care benefits had specific guidelines in order for the individuals to receive home health. Home health was covered under Part A, and it was limited to 100 days per benefit period, and you had to be in the hospital for at least 3 days immediately prior to receiving home care. Since that time, home health has evolved and expanded, and in 1972, Medicare eligibility expanded to individuals receiving Social Security disability, and in 1978 to individuals with end-stage renal disease. So it doesn't matter at what age you become disabled or develop end-stage renal disease, either of these diagnoses will automatically qualify you for Medicare. Okay, Becky, next slide. In the late 1970s, it was expanded to cover chronic healthcare needs, and I listed a few of the chronic healthcare needs that we typically see in home health: hypertension, chronic kidney disease, which could be related to diabetes, congestive heart failure, HIV or AIDS, and non-healing wounds. And it was seen as less costly than being in the hospital or a nursing home. It was considered to be a more humane way to provide treatment, as most older adults prefer to receive care at home. And studies have shown that home health is more effective than hospital stays for many patients. And the results show patients who were treated in a home-based setting were less likely to be admitted to the hospital and had fewer visits to the emergency room. And that brings a thought to mind. I was gonna, this is kind of a little bit off track, but I was reading in my AARP magazine that came out in the January-February issue, and they're saying that global aging is perhaps the most important demographic trend of our time, and by 2050, a sixth of the world's population will be over 65. And so there are many programs that are being developed to ensure access to healthcare services for older adults, strengthening the availability of long-term care, supporting aging in place, and caring for older people in crisis situations. For example, here in the US, the hospital at home programs work to reduce the strain on healthcare systems by offering quality care for older Americans in their homes. In addition, it supports many older adults' desire to age in place. The program has been adopted in Australia, Europe, and Asia. And while I was reading this article, they talked about the different countries that are partnering and learning about home health. And one of them is Thailand, and they partnered with Japan to create a community-based program to improve the care and coordination after an older adult is discharged from a hospital. And so they have volunteers and nurses that go in and help to manage care for these older adults. And then so the volunteers and nurses from Thailand are going to Japan and then coming back to their homes and training other nurses and volunteers. And I bring that up because it made me think about when I worked at St. Joseph's Hospital in Tampa. St. Joseph's is a Catholic hospital, and at the time, back in the 90s, the sisters that were still involved with the politics of the hospital, and they lived on the campus of the hospital. And one day, Sister Mary Catherine came to us in the home health department and said, you know, we've got some visitors coming in from Japan, and they want to learn about home health and the benefits, and they want to go back to their country and start, you know, home health program. And so we said, sure, we'll be happy to, you know, accommodate them. And my administrator at the time came to me and said, well, we're going to take them out to dinner, and we need a volunteer to drive Sister Mary Catherine. And initially there were no volunteers because everybody, they felt like, well, we have to be on our best behavior when we're with, one of the sisters, and they felt intimidated. So we decided to draw straws, and I drew the short straw. So I ended up driving Sister Mary Catherine. I pulled up to the residence in my Camaro, and she came out and said, "Oh my goodness, I love your car." She's like, "You have T-tops. Can you take out the T-tops?" And I said, "Sure." So we went driving down the highway, her with her habit on, and wind blowing in our hair, and we had the best time ever. We got to the restaurant, we entertained the nurses from Japan, and they went back to their country. They were very thankful for us allowing them to come into our agency and learn about home health. And so when I was reading this article, I thought, wow, that's awesome. I hope that, that was our opportunity to leave a little footprint on the rest of the world. So anyway, that's just a little sidebar that I wanted to bring up, and also to mention that, there are other countries now that are looking at trying to decrease hospital stays and save on costs. So currently the average reimbursement for home health is $1,900 a month or $63 a day versus reimbursement for nursing homes, which is about $7,600 a month or $255 a day. So you can see that there's definitely a cost savings with home health. And since the start of home health, the criteria has not changed. In order to receive home health services, an individual must have difficulty leaving the home. They either need to need an assistive device, or they need assistance from another person to take them out of their home, maybe take them grocery shopping, take them to their doctor's appointments. They also have to be in need of skilled care, so they require a licensed clinician to come in and provide care to them. They have to have a physician certified, so they need a primary care doctor that can review their plan of care. And in addition, the agency delivering the services has to be Medicare and Medicaid certified. Okay, Ms. Becky, next slide. Now, home health can be requested by a hospital or physician office at any time. A need is determined as long as the criteria that we just talked about is met. So there's no longer that, criteria that they have to have been in the hospital, and there's no limits, there's no 100-day limit or anything like that. So again, currently home health has evolved and anyone can request home health care at any time. And currently CMS utilizes a system that is called PPS, or Prospective Payment System. Over the years, CMS has utilized different programs and payment systems to oversee quality of care and to also rein in the cost of home health. And so right now, the current system that they're using is called the Prospective Payment System. And reimbursement under this model is based on a 30-day episode, and it also depends on the type of diagnosis. Previously, home health was, it was very therapy driven. It was based on the number of days that you needed therapy, the number of therapy visits that needed to be made, increased the reimbursement for home health. And so with the new programs that have come out recently with the 30-day episodes, Medicare is reimbursing based on the type of diagnosis, and it's no longer based on the number of therapy visits that you're getting. Home health rules and regulations are advocated by local agencies. So there are state and national home health associations that are available. They also send lobbyists to Washington, D.C. to meet with state representatives. And that's how changes are made to home health rules and regulations. They're guided by the legislators and then CMS once they've been approved. So Okay, Becky. So does anyone have any questions? The next slide is questions on how home health started or
That's a great image of you in the Camaro flying down the road. I
yes.
love that.
Cheryl?
Larry or Cindy, did you have questions or
Cheryl,
comments?
Yes.
Yes, I do have a question. I was just remembering recently that there has been some research studies that have been done in state of Washington and in the state of California, where they research what was the prevalence rate of Alzheimer's and related dementias in those states among the Indian population. And they found that 1 in 3 Native elders will be diagnosed with Alzheimer's within the next few years. And this is compared to 1 in 5. So the prevalence rate is higher among the American Indian population. And so knowing that, do you see that there is going to be an increased need for the type of care that home health is going to be providing? Do you see that as a potential for increasing needs for that?
Oh, yes, definitely. And the goal for home health or home care is to keep individuals at home as long as possible, right? So with Alzheimer's and dementia, they've got programs available where maybe someone needs someone to come in a few hours a day to help with bathing, to give their loved ones some relief. There's all different types of programs that are available, and I could see, in the future that there will probably be more programs available as the need arises.
Thank you.
You're welcome. And that's just a small snippet of, of the different programs, that are available out there.
Cheryl, there's a question about what are some of the national home health associations that are out there? If people, wanted to learn more or see what the requirements were to be certified or that sort of thing?
There is a National Home Health Association. It's called NAHC, NAHC, and you can join. Any agency can join their National Home Care Association, and then there's also state associations. Every state has a home health association, and we'll talk a little bit more about that later in the presentation. However, I would strongly encourage, and I've always been a member, even if my specific office or agency wasn't a member, I always was a member of the state association, because there's such valuable information that they can provide. They keep up with all of the new regulations. They keep up with the requirements. They are a vast knowledge and center for education and training.
Thank you. Thank you for that. There's another comment that says, I'm confused. I think a slide said a 3-day hospital stay was a requirement, but this past slide said no.
Yes, that is correct. Previously, that was the requirement. And that was back in the early days in the when it first came out in the 1960s, it was a requirement. But like I said, since that time, home health has evolved, and now there is no requirement. So that was just to give you an example of how home health has evolved as things have changed, and there has been an increase in the need for home health. There's no longer that 3-day requirement for home health.
Okay, thank you very much for clarifying. And that's what she's saying as well. Thank you for clarifying. Great.
You're welcome.
All righty. I don't show anything else right now.
Okay. All right, so we'll go to the next slide, and we'll talk a little bit about what steps need to be taken to receive home health. So, and this goes to one of the previous questions about, requirements for home health. So in order to receive home health, you have to have a primary care physician or PCP, because that's the physician that's going to be overseeing your care. You need to make an appointment with that primary care physician for a face-to-face visit. And that's one of the requirements for home health, is that every individual that receives home health has to have a face-to-face visit with their doctor. Also, the PCP may order home health based on medical issues identified during that visit, and they will contact an agency to send an order for home health. Now, there are instances where someone may need home health. They may call their physician up. Maybe a family member has noticed a change in someone's condition. Maybe they're a little bit confused. Maybe they're incontinent of urine. And so they can't get into their doctor's office. And so the doctor may order home health to go out and assess the patient and report back to them. And once home health goes out and they admit that patient, then that patient needs to make sure that they are seen by their primary care doctor within 30 days of the start of care in order for home health to be reimbursed. So that's extremely important. So these are requirements, additional requirements that have to be met in order for someone to receive home health. And I think I saw a question that came up.
Sure. It's Myra says, question to those, it sounds like it's open to everyone attending as well. A question to those present as to how home health comes onto the reservations. So I guess that's just open.
Well, I really think that in a lot of tribal communities, of the 575 tribes across the country, there are very few certified home health agencies across the country. And so this particular webinar is basically to provide information to tribes if they're interested in establishing a home health agency. These are the requirements that they have to meet. And the other thing that I think that probably Cheryl will be talking about later on is there are a number of ways that one can provide home health services in the tribal community. One, they can establish their own. Two, they can catch up or make an arrangement and develop a memorandum of agreement between the tribal program and an existing home health agency that might be off reservation. And that's how one might be able to make the home health program available much quicker on an Indian reservation than if there was if you were planning on starting one on your own. So that would be my comment on that.
Yeah, that's exactly right, Larry. So thank you for that comment, and we can talk more about that as far as trying to set something up in your community. So, all right.
I don't show any other questions at this point, Cheryl.
Okay. So let's talk a little bit about who covers the cost of home health. Medicare and Medicaid cover the cost of home health. Medicare covers anyone who's age 65 and older, individuals on disability, as we discussed before, or individuals with end-stage renal disease. Medicaid covers low-income individuals, which includes children and adults, and it includes individuals on disability as well. And as we talked before, each state has specific requirements and different programs that they offer. One thing I do want to point out is that you can be enrolled in both Medicare and Medicaid at the same time, because you could be 65 years or older, and you also could be, have meet the income requirements to receive Medicaid. So you can have Medicare and Medicaid we call it a dual program. And then managed care plans. A lot of people have signed up for managed care plans in an effort to save money. And there are specific guidelines based on the type of managed care plan that you may be signed up with. There are HMOs, which is a health maintenance organization, or PPO, which is a preferred provider organization. And they may have most of the HMOs and even the PPOs too, but they have a specific network of physicians that you can choose from. And they may require that a PCP at the time of enrollment, that you select a PCP to oversee care and give authorization for services needed. So it's real important to know what type of managed care plan that you have. And in home health, that's one of the things that when anyone in home health gets a referral, they will check the managed care plan to see what the specific criteria is. Because if you have an HMO, and sometimes that doctor with the HMO has to be the one to order home care specifically, and they have to give an authorization code and the specific diagnoses that the patient's going to be seen for. So there may be specific parameters. However, the agency would be the ones to investigate and then let you know what the criteria is for your plan. Also, managed care for Medicare and Medicaid recipients was started to improve care and lower costs. Insurance companies and our primary care physician they'll schedule regular appointments to monitor health and eliminate unnecessary procedures, which lowers costs. So some doctors will, depending on your diagnoses, will require patients to be seen maybe every 4 months. Some doctors, if you're fairly healthy and don't really have any issues, they may want to see you once a year. But this is an effort to make sure that the goal is to be proactive and to focus on prevention with these type of plans. Okay, next slide, Becky. So examples of managed care plans include, but are not limited to, and I just want to make sure everyone knows that every state has different names for different insurances, especially for Medicaid. However, most insurance companies cover people across the United States. United Healthcare is one of them. Aetna, they may be restricted in some states. Simply Healthcare, Blue Cross and Blue Shield, most people have heard of that. Anthem, CareSource, Centene, CVS Healthcare, Highmark, which is a product of Blue Cross Blue Shield, Humana, and the list goes on. So there are many, many managed care plans out there. Does anybody have any specific questions about managed care or who covers the cost of home health? Did anybody had any specific instances where they needed home health or a loved one needed home health and they weren't sure about how to go about getting home health or how it would be covered?
Cheryl, I was just going to make a comment here. I guess two things. There are some tribes out there that have their own tribal health insurance, and that it might be something worth looking into at the tribal level to have people look at their tribal health insurance programs and see whether that particular benefit is available within that tribal insurance program. Secondly, I think that one of the things that always presents a problem in Indian country is that, when we talk about the primary care physician, which the PCP guide, that in some tribal clinics around the country, the PCP is usually sometimes is not available because the doctors come and go. There's always been movement from one doctor to another doctor to another doctor. And I think that with some tribes that have contracted or compacted their programs, they should have probably a pretty stable number of physicians that are staying with that particular hospital. And that makes it a lot easier to have a primary care physician. So I just thought I'd just note that just for everybody's thinking as well. Thank you.
That's a good point, Larry. And it sounds a little bit kind of like the VA. So there may be the opportunity if there is a specific supervisor of that clinic, because, you know, there usually is a physician that supervises. And even if you have several doctors that move around and move in and out, as long as there's maybe one person that's supervising, even that person could be the one that's considered the primary care physician. So, but that would bear some looking into, as you mentioned. So, and kind of thinking outside the box there.
Thank you.
You're welcome. All right, any questions from anybody? Okay.
Cheryl, something just came in from Rowena. It says with Medicare, there is so many parts to it now. Where does HHC fall under? And once receiving HHC, does Medicare for the individual increase?
Well, I'm not sure I understand the question. As far as home health care, the if a person is Medicare eligible, or if they're on Medicare, then they can receive home health care, you know, no matter what, as long as their doctor has ordered it, because you have to have a physician that signs the plan of treatment. And I want to point out also that now CMS recognizes nurse practitioners. So nurse practitioners, of course, we'd have to check in each state to make sure that the state allows it as well. But a lot of times nurse practitioners can sign off on the plan of care. And this just came about since COVID, where nurse practitioners now are allowed to order home health and also to sign a plan of care. But as long as you have Medicare, you know, home health is covered. So I'm not sure if that answers your question, or.
I could try, we're learning about how to use Zoom, and we can unmute Rowena if she would like to ask her question to you directly. That would be helpful.
Okay.
Rowena, gonna unmute you. So if you'd like to.
Hi, Rowena.
Hi. I was asking the question about Medicare because, well, first of all, my father is not Medicaid eligible, so he has to go and use his Medicare. But I
Okay.
was just kind of wondering, you know, with home health care, where that is covered, and there's like Part A, Part B, Part C, you know, it goes on. The other part of my question was, once he does receive any type of home health care, well, his Medicare benefits, well, his portion of it paying into it, will that increase?
No. What he pays right now for Medicare will not change. The only time that changes is when there's a law across the board where it changes for everyone. There's no limit on receiving home health, as long as, you know, your father would continue to meet the criteria established by CMS. And Medicare Part A, it covers it 100%. Medicare Part B is usually for, like, say, for instance, if he needed any type of durable medical equipment, Medicare would pay 80% of his any type of medical equipment that he needed in home health, and then he would be responsible for the other 20%.
Okay, thank you.
You're welcome. Did that answer your question?
Yes, it does answer my question, and I just sounds like I still need to do a little more research.
Okay, and Desiree, I'm not sure where do you live right now?
Rowena, I think.
Oh, me?
Yeah.
Okay,
Yes, ma'am.
Rowena, I'm sorry. Rowena.
I live in Crown Point, New Mexico, which is on the eastern part of the Navajo Nation. And there's IHS here, and I know there's different types of programs that are available, but I just, when it comes to inpatient stays, I had to look and find out what was available and I'm trying to understand everything with Medicare, Medicaid, and just so that I can be helpful when it comes time to, that's why I have to go ahead and look into a lot of stuff.
Yeah, and if you have additional questions, there are multiple agencies, you could, call up an agency in your area and they could tell you exactly, what they could provide for your father, but there's no inpatient stay requirements or anything like that in order to receive home health anymore.
Okay, I thank you for that.
You're welcome.
Cheryl, this is Larry. I was just thinking that one of the things that the difference between home health services is it's more medical and it's physical health type thing, whereas home care is kind of like home chore type services. And in Navajo, having been the executive director of the Navajo Department of Health a few years back, which I was twice, by the way,
Okay.
we have CHRs, community health representatives, that do that type of service and that provide that type of service. And they should be providing that type of service on the home care side of it.
Okay, good. Well, that's additional information, Rowena, for you.
Cheryl, there is a question from Helen. And Helen, we can unmute you if you'd like to ask the question, or I can read it. If you'd like to go ahead.
You're welcome, Rowena.
Helen, are you there? She may not have a microphone or something, I don't know. But her question is Medigap plans covered for home health?
Yes, you have to look at the specifics of the Medigap program to see, because usually that is a state sponsored type of thing, and so we would have to look at the state requirements for coverage for that.
Okay, Helen, does that answer your question? Just let us know if you have any other things you need to clarify, okay?
Hi, this is Cindy. Yeah, I think that's in reference to, that's a Medicare C, so it's like Medicare Advantage. And with those, there are insurance companies that provide those Medicare Advantage programs. And when a person goes in to sign up for them, they can pick a plan that suits their specific medical or pharmaceutical needs. And so that question, it depends on which insurance company you're going through and what is covered on that specific plan. Yeah, and some insurance companies are just specific to like the one immediate state and they're not nationwide.
Correct, yep.
I am going to, it looks like Lorna would like to speak, so I'm going to unmute her. Please go ahead, Lorna.
Oh, okay. I was typing in the chat. So community health representatives home care is actually limited. It's a limited time set. It may be 30 minutes, if even that, with that they can go into a person's home and assist. because they have an abundance of other duties and other people. I have like 193 elders, and even with COVID, and the chore service was pretty much limited. We don't do the dishes, we don't dump the garbage, we can sweep, no bodily fluid stuff. It's not actually in all answer. What they have is what's called personal care attendants, and a person that's related to the individual can get CPR and be trained to care for them as long as they do not live within their home. And they have to get state certified, which is not much. But the thing is, they don't know how to do the billing. They can bill Medicaid or Medicare for their services, but they need to do the accounting for that.
Thank you, Lorna. Sounds like you're busy. Wow.
Mhm. Really.
Thank you for sharing that insight, because I'm sure every tribe's got specifics, and this is a complex subject we're taking on. So thank
Yeah.
you for everyone for sharing their point of views. And yeah, so I don't show any other, there was a comment, Angie says, good question, Larry. We have doctors that come and go, when he was referring to the Alzheimer's. And Louis was thinking she may be confusing home health services with home care services, which I think we clarified. And Rowena says, thank you. So that's all we show in the chat.
Okay, thank you, Becky. All right, so we'll go on to the next slide. So what type of care or service is covered under home health? There are nursing services that are available to help with education, and I just listed a few diagnoses. This is definitely not all inclusive of everything that a nurse would do. But it is important to remember too that they're following the physician orders. And I'd like to add also, in addition to all of these things, education regarding diabetes for those of you all who may be on your phone and can't see the slides, high blood pressure, kidney disease, breathing problems, pain management, review of medications to ensure physician instructions are being followed, wound care, IVs for hydration, IV antibiotics, nursing. There's a lot of things that nursing can do. Also, physical therapy is there to help individuals with balance and learn how to walk and reduce and prevent falls. And I want to point out that falls is a major reason for hospitalization or rehospitalization. And that's another reason why home health may be ordered to go in and do some investigating to figure out what is causing falls and to see what can be done to prevent them. I once had a patient that this patient was in an assisted living, and she would have falls at night. She would be up all night. She would fall and hit her head. They would have to call 911 and rush her to the hospital because she hit her head. And she was, keeping everybody up all night. And the doctor ended up ordering home health to come in to do some investigation because they couldn't figure out why she was having so many falls. And one of the things that we identified is that she was getting Lasix twice a day, which is what we call a water pill. It pulls fluid off of your body and it makes you go to the bathroom. And so she was urinating all day and all night. And come to find out, she'd be sitting on the toilet and she was so tired that she would fall asleep and fall off the toilet and hit her head. So we talked to the doctor about changing her medication and making sure that she's only taking the Lasix earlier in the day. And also got an order for occupational therapy to come in, and they were able to get an addition to the commode that would keep her from falling forward off of the toilet. So, that's an example of, home health and one of the benefits, because we go in and we investigate and we try to figure out what the problem is and what we can do to help fix it. And this patient was able to sleep at night and other people were able to sleep as well. So everybody ended up being very appreciative of having home health come in and help them with this patient. Also, physical therapy can assist with making muscles stronger after a stroke or a hospital stay. And we talked about patients that there's a lot of patients that are going home from after having COVID to recover at home. And as I mentioned before, they're weak. And so physical therapy is able to go in and help. That's an example of being able to help them to get stronger, doing specific exercises, giving them a home exercise program. And then occupational therapy is available, which we just talked a little bit about, but they can help with training on learning how to get in and out of the bathroom, on and off the toilet, how to manage around the house without falling or tripping, and assist in gaining strength back after a fall, stroke, or a hospital stay. And, occupational therapists get very creative as well, and they've got specific devices that they can use, reachers to help people if you can't bend over. Maybe you've had surgery and your abdominal wound is keeping you from bending over. They have sock aids to help you be able to put on your socks. So there's all types of things that occupational therapy can do as well. Next slide, Becky. Also, speech therapy is available. They can assess swallowing difficulties, which are common after a stroke, or if an individual has Parkinson's, or maybe they've had a head injury. They can instruct on how to manage swallowing without choking. And they can also assist with exercising the brain if an individual is becoming forgetful or have suffered a stroke. And speech therapy is also important for patients. Larry, you had mentioned about the increase in Alzheimer's and dementia diagnoses. They can also help with those type of diagnoses, especially if a patient is having difficulty swallowing, or maybe they can perform exercises to help with memory. Medical social services is available. They assist with identifying additional community resources. So if someone is financially challenged, maybe they've been affected and don't have enough food or money for food or clothing, they can assist with long-term planning if needed. And then social workers can do counseling if they're a certified or licensed counselor. They can counsel patients that have depression or anxiety. Okay, Becky, next slide, please. Okay, and under home health care, individuals can also receive a home health aide. They can provide assistance with bathing, light housekeeping, light meal prep. But the caveat for that under home health care if they're receiving Medicare-certified services, then they have to also be receiving nursing or therapy in order for home health aid services to be covered, because the aide has to be supervised by either the nurse or the therapist. And hopefully that made sense to everybody. Does anyone, next slide, please, Becky. Does anybody have any specific questions about what type of care is covered under home health? I know we talked a little bit about that previously. The thing that I want to also stress too is that it's important to know what programs are available under the Medicaid programs in each state. If there are individuals that qualify for Medicaid, the state is really, I've seen the state programs come a long way where they're providing aides to come in and help with meal prep, like housekeeping. They'll be in attendance with that person for 4 to 8 hours a day, depending on what their needs are. And at the same time, under Medicaid, if they're not getting home health under Medicare, sometimes Medicaid will also pay for nursing. So that's why I say it's important to know what your state requirements are. I know in Alaska, they've got a program called Denali Care that's administered by the Alaska Department of Health and Social Services. Arizona's got specific programs. So, every state has some type of Medicaid program, and it's very easy to find that information if you've got internet service. Okay, no question?
I'm not showing any now.
Okay.
Larry and Cindy, do we have any comments or questions?
No, I think she covered it well. Thank you.
All righty.
Okay, well, let's go on to the benefits of home health. So home health promotes wellness, and I've just listed a few things that you could benefit from home health. And, a lot of times, one of the most common diagnoses that we see is hypertension. So, and that's high blood pressure. So one of the benefits is having a nurse come in and teach someone how to lower their blood pressure. A lot of times it's just a matter of taking medication, making sure that they're taking the medication, making sure that they've got the ability to get that medication. Maybe they need some dietary teaching on what type of foods to avoid, stress reduction techniques. Also, preventing urinary tract infections. This is another common diagnosis in home health. And sometimes people will become more confused, and a lot of times it's because they may have a urinary tract infection. Maybe there's a strong smell of urine when they go to the bathroom, and that's nursing can come in and take a sample, and there are even tests that can be done right at the bedside to be able to diagnose a urinary tract infection, and the doctor can order the appropriate antibiotic right away. And then, as we talked before, recovery from COVID-19, how to prevent spreading the virus. And that's just to name a few of the items for promoting wellness. Also improves healing. A lot of times patients will go into the hospital to have some type of surgery, and maybe the doctor wasn't able to close up that wound, or maybe there's a special type of dressing that they put over the wound that they want to be monitored. And so nursing can go in and assess that and make sure that there's to decrease the risk of that wound not healing or decrease the risk of infection. IV antibiotic infusions, and that's something that home health can come in and do and teach patients how to do their own IVs. And a lot of times, people will be like, oh, there's no way I can learn how to do that. But I have taught so many people how to do their own IVs, and it's amazing at how well people do with that. And then non-healing wounds. A lot of times you'll see non-healing wounds, especially with patients that have diabetes. And so it's just a matter of maybe getting those blood sugars under control and making sure that people are eating enough protein and getting those wounds to heal appropriately. And then another benefit is individuals will have someone to talk to about their concerns and illness. They're able to ask questions. I had a patient that he was very private. The doctor ordered home health after he'd had surgery. And one of the questions that we always ask when we go into a home, most nurses do, is you want to assess their bowels and make sure that they're having a bowel movement. And he would always say, yes, my bowels are moving, my bowels are moving. Well, he started becoming very irritable, and I could tell that this patient was miserable. And finally, his wife pulled me aside and confided that he had not been moving his bowels as well as he said he had. And so come to find out, he was very, very constipated. And so we ended up having to call the doctor and get an order to disimpact and to give him an enema. And after I left, he felt so much better, and he tried to pay me, and I told him that we can't accept money. There's no way, but I was very happy that he felt better, and that just gave me validation, to make sure that the patient was feeling better when I left. Also, it decreases isolation and loneliness, which can affect health and recovery time. Individuals may not have enough food or resources to care for themselves. If they're isolated and no one's going in there to check on them, then you may not know that this is one of the problems that they're having. Individuals may not have enough money to buy their needed medication. They could have health issues or concerns that are not being addressed, and that can lead to chronic health issues. And then isolation can lead to depression and or anxiety. And so, it's just very important to try to make sure that, we are able to check on people that may need our services. And I had a patient once that lived alone, and the doctor had been trying to get home health to go out and see her. She kept canceling her doctor's appointments. And this was a patient that had problems with her blood pressure. The doctor knew that she was high risk for hospitalization. And, even doctors now are, it's part of their reputation to make sure that they keep their patients out of the hospital. And so this doctor proactively ordered home health, but when we went out to see the patient, she would not let anybody come into her home. And we can't force our way in, but she just adamantly would not. And typically we would wait a couple of days and then we would try again. Well, her sister, she always talked to her sister every day. Her sister lived in another city, and they would talk every day about the soap operas. And one day the sister tried to call her and couldn't reach her. And it got late into the evening. And then the next day she still wasn't able to reach her. So she called the police to do a wellness check on her. And when the police got there, they found that she was confused. She was able to answer the door, but she was confused. She had definitely been incontinent of urine, and they could tell that that there was something wrong. So they called 911, and she ended up going to the hospital. And this woman had suffered a stroke. It wasn't a major stroke, but she had suffered a stroke. And once she recovered, they sent her home with home health. And one of the things that we did was we would go in and monitor her with her medications. And also we noticed that her front porch was very rickety. And so we ordered social services to come in, and they were able to find someone to come out and fix her porch so that, she would be safe, whenever she was out on the porch. And her sister and her both were very appreciative of the services that we were able to provide once we got in to see the patient. So that's just an example of, when someone is isolated, you don't always know what's going on until it's too late. You're welcome. All right, so next slide. Does anybody have any specific questions about the benefits of home health?
Cheryl, I don't know if you saw, but Rundell had to jump off for another meeting, but she said great presentation. So thank you.
Good.
And then Angie says, thank you, Cheryl. Very informative presentation. I did not know too much about home health care until now. So that's good. Yeah. And I wanted to make sure, and Lauren's joined us. Hey, Lauren, agreed, very helpful. Yay, Lauren's wonderful. And I wanted to make sure everyone knows to check out the NICOA website. We have a section on connected Indigenous elders, and that talks about that topic of social isolation and how important it is, and how, having someone visiting your home on a regular basis is so important. And caregivers suffer from those sorts of things as well. So there's a lot of good information there, and I wanted to make sure people visit that if they can. Larry and Cindy, did you want to jump in?
Yeah, I just wanted to add here, Becky, that in our website, we have nicoa.org. And that's one, the major, the larger website. But then there's the NICOA Compass website. And where I think that's where we have that information available. I think that one of the things that you just mentioned, Cheryl, is that when the home health nurse visit that individual in the home, and there was a call to the police department, and then there was a call to the social services department. This is what we're trying to do from the National Indian Council on Aging, is to make sure that as we start talking about caring for our elders, that it's not just one agency that's providing those services. It's a coordinated, collaborative approach to how we serve the needs of our older people. And so when we're talking about LTSS, long-term services and support, that's basically what we're talking about. We're talking about the police department, the fire department, the social services department, law enforcement, even Head Start or education or high schools, as a coordinated approach to how we provide the best care that we can to our individuals. And the idea basically is that we want to keep our elders well as long as possible. Those who need services, supportive services, we want to provide them with services so that they stay in the home as long as possible. Inevitably, at some point, there's going to be a need for long-term care services or long-term care facilities. And that's why we're talking about doing a webinar later on in the year on assisted living facilities. So I just want to just kind of give a broad overview, and thank you, Cheryl, for that example.
And this is, I think the one comment that I would like to make is, you know, as being a health director for a few different tribes, and one of the concerns is limited funding, especially for the smaller tribes. And I think the one thing that they need to take into consideration is, to some degree or another, tribes are already providing some sort of home health services, home care services, some home health care services, and they're worried about it being cost prohibitive. But if they get all the departments to work together with between the clinic and social services, the clinic has, you know, mental health, they have behavioral health, there's a senior center, and all the other outside departments, and they come together and create an MOA, they can create and do cost sharing for building space, materials and supplies. You know, the clinic can do the billing, all of that. So it's not as cost prohibitive as they may think. There's still hurdles that they will have to jump, certifications and all of that. But they may want to, if they're even remotely thinking about starting up a service like this, is bringing all of the departments together to start discussing this and go over how they can do the cost sharing to make this happen.
Very good. Yes. Thank you.
Thanks, Cindy. Hey,
Mhm.
Cheryl, I'm sorry to jump in. Kristen had a comment, and we can unmute her if you'd like. Kristen, I can click the button and let you ask your question if you'd like to.
Sure. Are you able to hear me?
Yes.
Okay, so I'm wondering the best way to get social services involved. The experience that we have here in our clinic system is we also have community health representatives that do home visits, but very limited, just pretty much to check on the patient, to see if there's anything they need. But sometimes they do notice that there are additional services needed, or if we have a patient with dementia, for example, who are not able to really live in the home independently, safely, but it's hard to get enough help for them through their insurance. They have limited hours of like in-home supportive services. And so we do adult protective service reports at times if there's abuse or self-neglect.
Yeah.
But other than that, I'm not sure how we could get social services involved to help us connect this person with resources that we're not able to get them. Like, we can only do so much, but those type of agencies have more of a gateway to make those things actually happen. For us, it's kind of like we go in circles and we're not really sure how to access ways in to get more services at times.
I have maybe some helpful comments on that. One of the tribes that I was a health director at, it was becoming more and more apparent that we had patients out there, especially elderly patients, that were falling through the cracks. And as a way to start addressing that, I got together with all the different departments, including social services, and we formed like a care coordination group. And we would meet on a regular basis. We started out weekly, then bi-weekly, and later on it became monthly, more if needed. And so that included all of the departments, from social services to the different clinic departments, the police department, and courts as needed, senior center, a CHR, all of them. And we would discuss the needs of and we did a confidentiality agreement and an MOA, and everybody had to sign these, so we were not in HIPAA violation. And then we would discuss the patients that we shared in common. And by doing this, we were able to better address the issues of a lot of the patients out in the community. Sometimes they don't like coming into the clinic. There's dynamics that go on there. They may not like somebody that's working in the clinic, but they may go to the senior center. And so you can get a lot more information about the needs of the patients if you form like a care coordination committee. And then through that, start discussing the needs of the clients that we share, or this client may need these services from social services. And again, that's all about, the different programs coming together to provide these services. And once we started doing that, we were having a lot less episodes of things happening with elderly people out in the community because it wasn't being caught or addressed.
So what do you consider social services? Because our system, we service 2 counties. We're not on, we have tribal members or non-natives. We're on and off reservation, cities, everywhere. So
Wow.
we're dealing with so many different agencies. So I don't really like.
Now, let me ask you a question, Kristen. When you say different agencies, what agencies are you talking about? Are you talking about the clinic agencies? Are you talking about other home health agencies?
Well, we rely on like Office on Aging.
Okay.
It's just different for each person, depending on where they live, what insurance they have, what the situation is, of course.
Well, depending on the type of insurance that they have, they may have a home health benefit. I don't know if these patients are Medicare eligible or if they're on Medicaid, but either of those will allow them to receive home health. And home health can provide a social worker. They would have to have a nurse or a physical therapist come out and evaluate that patient initially, and then they could get social services out there to help, problem solve depending on what's going on with the patient.
Okay, so you would say probably going through the insurance and where they have and request a social worker from them?
Well, I would go check with the insurance company to find out what the home health criteria is. And then, you'll be able to determine if you can just automatically request a social worker, or do you have to go through a specific, does the agency have to send out a nurse or a therapist first? and then they can bring out a social worker. Because under home health guidelines for Medicare, social services is not a skill. So you'd have to have either a nurse or a therapist go out and see the patient initially, and then they can get social services involved after they go out and see the patient.
Okay. Thank you.
You're welcome. All
Don't
right,
show any other questions, Cheryl.
Okay.
Sorry.
then we'll move on to the next slide, please. So let's talk about barriers to providing or receiving home health. A lot of times, as I mentioned before, the patient that we had that did not want us to come in, she's very private. Sometimes they don't want someone coming into their homes, or there's a misconception that they'll be taken out of their homes, or they may not want anyone coming in to tell them what to do. They're like, who is this person to come into my house and tell me what I should or should not be doing? Or they may be embarrassed about their living conditions. I've been in homeless shelters. Back before they had to have a specific shelter, I even saw, a patient that lived under a bridge. There are people that live out of garages. I've run into situations where there's no running water. So they could be embarrassed about those type of things. Myths about being put out of an individual's home or losing our home. There are trust issues related to that. And so, they may not want someone coming in because they're worried that, I don't want anybody to come in and tell me that I can't stay here. Is Kristen, as you were talking about calling adult protective services, a lot of times people think that that's what's going to happen, and that's only if that person, if it's truly a dangerous situation. Otherwise, home health, the goal is always to try to keep that patient at home. And then also, agencies, staff members, people are maybe concerned that their information will be shared with other people. And, we have to maintain HIPAA compliancy. So the only time that you can share a patient's or individual's information is if you're coordinating care with another agency, like Cindy was talking about. So if you're coordinating patient care, then you can, talk about what's going on with that patient. But to just talk about what's going on with a patient that you're seeing with someone else, just to, gossip about it, that's a HIPAA violation. So that's definitely not allowed. But people are concerned about that. Okay, Becky, next slide, please. So how do we overcome those barriers? Well, I've always taught clinicians that, when we go into a home, we have to be non-judgmental. We can't always expect everyone to live the way we live or live up to a certain standard. If someone's been in their home and this is how they've been living all their lives, it's not up to us to come in and change things. We have to show compassion. We have to show kindness and respect. And I would say that, that is the most important thing, because when you show people kindness and respect, it's like they will open up to you, they will receive you in their homes. It just changes the game. And then finding out what an individual wants, what are their goals? Maybe they just want to be able to walk out to the mailbox and and get the mail. That seems like a small feat to us, but that might be what one of their goals is. Or getting to know an individual and what's important to them. Maybe they want to go to the bathroom and manage their own hygiene. I know that for me, if I ever get to the point where I'm having problems getting up and down or going to the bathroom, I don't necessarily want someone else to have to come in and manage my hygiene. I'd like to be able to do that myself. And then letting individuals know, what you're there for and how you can help them to achieve their goals. Talking to them about what their goals are and then what you can do to help them achieve those goals can, and in a non-threatening way, can make all of the difference. Okay, Becky, next slide. Does anybody have any questions about barriers or how to overcome those barriers?
Cheryl, you must have a lot of experience in finding people that can do all those wonderful things, like be compassionate and non-judgmental. And I think Larry, maybe I'm stealing your thunder, Larry, sorry, but trying to hire people like that can be hard. And do you have any tips?
Well, I would say that the majority of people that apply for a home health position, um, nurses and therapists in general, they have a compassionate heart. I mean, that's pretty much what led them to that occupation. But when you're doing the interview, you can you can have them tell you about different situations that they've been in and how did they handle those situations so that you can kind of get some insight into the type of person that they are. I always said, even when I worked in hospice, we would always look for that person that had that hospice heart, that as you can see from this picture, someone that's going to take the time to sit with someone and listen to their stories and just, pay attention to the things that are important to them. So you want to ask questions so that you can get an idea of the type of person that you're hiring.
Thank you.
You're welcome.
Larry and Cindy, do you have anything to?
I think that's just I have a comment though. I think that one of the things that I've dealt with working at the tribal level, I've been doing this for a number of years, is that people that sometimes come into an organization and all they're doing is looking for a job, and that 8 to 5 type mentality, and those are not the kind of people that you want working,
No.
especially with older people. And I've been taught years and years and years ago that you go into the work and your work should be fun, and when that work becomes a job, it's time for you to leave. And that's really hard. It's really difficult to find those kinds of individuals who really want to put the effort, the passion, the commitment to working. So it's really have to interview almost in a non-traditional manner to find out how they feel about it. Just a comment.
Yeah. So true. So true, Mr. Larry.
Cheryl, Helen Brumley has a
Question.
she has a question. Are you able to speak, Helen? Oh, yes, she's raised her hand. Yes.
Okay.
Go
Can
for
you
it.
hear? Can you hear me?
Yes,
Yeah.
ma'am.
Okay. The thing about and dealing with home health through a tribal agency. Both of my parents, my dad had ALS and he was there at the home. He stayed at the home until his passing, and my mother had Alzheimer's. But the thing with the tribal agencies, I never was specific on their roles. For instance, the RN came for my mother maybe twice a month, once a month, twice a month. And she, again, my mother's diagnosis was Alzheimer's, and she would ask questions, that my mother, there was, she could say anything. They weren't necessarily correct or anything. And I really thought that was sometimes a waste of time of not only the RN's, time, but, of course, my my mother was glad to see somebody, but I really felt, when I would get her Medicare billing, what that nurse cost to come, and she probably traveled about 40 miles to and from her location where her work location was. And I just, the things and I would ask the nurse, are there other specific things that you can do for my mother? I can answer your questions because I'm here all the time, or the caregiver that we have stay here, she can answer your questions because she's with my mother during the day. But asking my mother questions, you're not going to get a true, a true picture of what's going on with mom. And I never did get a description of what her job was, or really, where we were going with that. And so I just, I said, it's not really necessary, because I'm not seeing any benefit in it unless you can tell me what the benefit is on it, because mom is not getting anything out of your services other than, you're another person coming in her home, and she, she's seeing you, which I suppose social wise that's good for mom. But I just felt like her skills and her degree and her talents could have been used in a better way. I know one time I said, well, can you cut mom's toenails? No, she couldn't do that. There wasn't anything that she was really utilizing skill wise to help my mother, that I couldn't do, or that the caregiver wasn't doing. So I really, I don't know. I guess,
I hear you, Helen. And, a lot of times, family members, loved ones will ask specifically, well, what is home health doing? So my, as an administrator, if anyone would call me up about that, I would always pull up that patient's plan of care, which includes the orders that come from the doctor. So that doctor may have given that nurse specific orders that she needed to follow. And even though you may not have seen the benefit, maybe that nurse was reporting back to the doctor the things that she saw. And but again, I would encourage anyone, if you have those type of questions, to always call the office or call the doctor to find out exactly why they're having the nurse come out, when they do come out. And then I just want to make a comment real quick about the toenails. No, home health is not allowed to cut toenails, because normally what they will do is order for a podiatrist to come out, or for the patient to go and see a podiatrist, because cutting toenails, that opens up a whole nother can of worms.
Right. Well, the benefits that and again, I asked her directly. I never did get an answer that I was satisfied with. So I just, I discontinued the home health with my mother, because again, I didn't see the benefit of just, her sitting there and asking questions for my mother that she could not answer correct. I mean, my poor mother, her answer of 30 minutes and then 20 minutes later was going to be entirely different.
Yeah.
So
yeah.
I didn't see the relevance in it.
Well, and it's hard for me to answer that type of question without, having all of the information. But for anyone on this call or that has any of those type of concerns, I would encourage you to call and speak to the clinical supervisor of anyone that's coming out to get more information if you're concerned about the care or services that your loved one is receiving in the home.
Okay.
All right. Well, thank you.
I'm sorry, Cheryl. We are getting to the end, and we still have so
Okay.
much more content to cover. I just wanted to quickly mention that Shelley has a message for you, which I'll make sure you get, Cheryl. She's interested in more talking with you more. And then Maria, I'm sorry, I'm saying that wrong, says you have to have the heart of it for it to take care of elders in the community. And that's for sure. Yeah, so that's all we have in the chat.
All right, well, then let's move on. Let's talk about what's needed to set up a home health agency. So next slide, please. Yeah, there we go. So each state has different requirements to establish an agency. First, you have to apply for a Medicare Medicaid license. And then you have to determine, does that state have a certificate of need? Back, in the 80s and 90s, most states had a certificate of need, meaning that, for instance, if there's a hospital that comes into a specific community, they can't just build a hospital. There has to be a need for that hospital. And then the state has to approve that need. And if they feel like everything is super saturated, they may say there's no more need for another hospital. And the only way you could start up, you could advance with another hospital or another home health agency is if you bought a certificate of need from someone that already had another home health agency. So, but a lot of states since then have done away with the certificate of need. And so I've listed here specifically Arizona does not, New Mexico does not have a certificate of need, Alaska does not, Florida and North Carolina don't have a certificate of need for home health, but they do for hospice. So I just wanted to bring that up because you have to know if there's a certificate of need requirement for each state before you would apply for a license. And then state and federal guidelines need to be followed. And it's also depending on any types of tribal agreements that you might have, in your communities. Then you would need to appoint an administrator to manage the agency. You need to appoint a director of nursing with a valid RN license to provide supervision and or manage all of the personnel who provide direct patient care. And I want to point out that the administrator can be a nurse, and then they could have a dual role, so they could be the administrator and the director of nursing. And I don't know if any of you all are aware, but I do know like the Cherokee Nation, the state of Oklahoma contracted with them to actually start up a Medicare Medicaid home health agency in the state of Oklahoma. So, and their agency is open to anyone that needs home health, although I think the majority of the population that they serve are from the Cherokee Nation. Okay, next slide. So staffing requirements, as we had mentioned before, you have to have registered nurses, physical therapists, occupational therapists, speech therapists, home health aides, medical social worker, and then a licensed practical nurse is not required, but you can hire them because it does save on cost, but they have to work under the supervision of a registered nurse. Okay, Becky, next slide, please. Additional staffing needs, it's highly recommended to contract or appoint a medical director that's also a licensed physician to assist with additional oversight and specific duties as needed. This helps to maintain quality in the agency. You also have to have specialized coders to ensure the correct international classification of diseases, or what we call ICD-10 coding for appropriate diagnoses and reimbursement purposes. And you need to have a staff the billing department to oversee and facilitate appropriate billing practices. And you need IT specialists to manage the software that interacts with CMS, which is the Centers for Medicare and Medicaid. Okay, Becky, next slide. So that's just a brief overview of what you would need initially to set up an agency. And for anyone, if you want more information, you can always, like I said, if you have internet services, you can go to the internet and find out what's required in your state as far as the license application is concerned.
Hi, Cheryl. I don't show any questions.
Okay. So let's go on to the next slide. There are pros and cons of establishing and starting a home health agency. And some of the pros are that it allows flexibility in operational directive and oversight of owning and operating a business. It allows for profitability when managed appropriately. It allows an agency to make a difference in the lives of the people that they serve. And then there's the potential to grow as requests for services increase as the population ages. You know, there's a lot of work involved in setting up an agency. However, you know, it does allow you to own the business and take care of your people, and then also to contribute money to your bottom line. Okay, Becky, next slide, please. So some of the cons are you have to create an annual budget and you have to monitor it to ensure profitability. Staffing is a constant challenge, so you have to recruit clinicians and you have to supervise those clinicians 24/7. So you're accountable. There has to be somebody accountable 24/7. So always have to have an on-call person. And then you have to keep up with the regulatory challenges, including all the annual updates, and have resources in place to monitor the CMS websites. And then national and state association membership, as we talked about before, is invaluable in getting the information to keep up with the annual updates. Because if you don't make any of the changes for the annual updates by the deadline dates, it can result in fines or even closure of your agency. So that's why I always made sure that myself or the agency I was involved with was a member of the state association. Okay, are there any questions regarding that?
Some folks have had to leave, but they'd say great presentation. They thank you for all the great information.
Okay, thank you. All right, next slide, please, Becky. All right, so utilizing an already existing agency. If you were to utilize an existing agency, which it sounds like there may be a benefit to some of the people on this call, it allows you to have an individual choice of that agency. You're able to choose a reputable agency from the Home Health Compare website. So this is something that CMS requires every agency that's Medicare, Medicaid certified. They have to report their quality outcomes. And this is a way for people to know how they score. And then you could use that website to determine, what type of, which agency you might want to utilize. Also, it allows the ability to work with licensed clinical staff that have already been screened and hired, the ability to access medical protocols to manage individual care and health issues, and it removes the need to keep up with regulatory requirements. So basically, you're letting someone else do the heavy lifting while you make sure that your people are taken care of. Okay, so any questions? That brings us to the end of our webinar. And so I just want to thank you all for the questions that you've had so far. And does anyone have any questions about utilizing an existing agency or anything else that we've talked about?
Cheryl, there is a question that says, what is the startup cost range when starting from scratch versus utilizing an already existing agency?
Well, that's where it would come in, where you would have to put together a budget and do a cost analysis to see the benefits to that. To apply for a license, it's about between $1,700–$1,800 to apply for a license. And then you have to think about, you need to have a business license, which only the average is about $50. And you have to determine what your rent, utilities, furniture costs are going to be, salary costs are going to be. And so initially, I would say it would be anywhere from $250,000 to $500,000 because you're going to have to pay people to do the work until you're able to bill and start receiving money back from Medicare or Medicaid.
Cheryl, I
Thank
have a
you. Yeah.
Cheryl, I have a question real quick.
Yeah.
I know that in the nursing home industry that when you start up a nursing home, you better have enough money in reserve, right? At the very front end money. So you can pay every one of those people until you can get yourself certified, get the inspections, you can take
Correct.
a look at the quality of the care, and then it will probably be 2 or 3 months until you get your money back from Medicare.
Right. Yep. That's exactly right.
Cheryl, would you like me to go through to the end with the resources? or-
Well, no, what I would like to do is just to leave you all with a last riddle. Again, I want you to put on your thinking caps and I want you to think about the answer to this riddle. And hopefully what I've given you will help you maybe shed some light on it. But anyway, here we go. I have cities, but no houses. I have forest, but no trees. I have water, but no fish. What am I? And I'll repeat it again. I have cities, but no houses. I have forests, but no trees. I have water, but no fish. What am I? Larry, I bet you know the answer to that.
I'm sitting here trying to get my 5th cup of coffee going and my brain's not working all that sharply.
Does anybody want to take a guess? Okay, I will tell you. It's a map.
Oh, good one.
So I have laid out a map basically for you to utilize to determine the benefits of home health and how this would benefit each individual on this call. So if you have any questions or concerns, Becky, you can go to the next slide. These are the resources that were utilized in putting this presentation together. Next slide. And there's all of our information if you would want to get in touch with us. Becky, did you want to add anything else?
There's the link for all our websites if there's a question. And as Kayla mentioned, the recording and the PowerPoint slides for Cheryl's talk will be posted both on the NICOA website and the NICOA LTSS Compass website. And then if you'd like to reach out to Cheryl Ingram directly, please feel free, and here is her email listed. We are going to do we have more webinars planned in the future. The next one up is the Assisted Living webinar on April 6th. And please check our blog for more information and to register. This has been such a rich conversation, Cheryl. Thank you so much for, you're so easy to talk to. You're so smart. You've done so many things. It's really been lovely to learn from you. So thank you.
It's been an honor to work with you all as well. I've definitely enjoyed it and I appreciate you very, very, very much.
Thank you, Cheryl. This is Larry Curley. Thank you very much. And for everybody that was in on this conversation, thank you for being here. And hopefully you learned something about the home health programs. And as I said, that's what we're here to do, is to provide you with that information. Again, thank you very much on behalf of the National Indian Council on Aging.
All right. Thank you all. Have a good rest of the day.